Well, all right, everybody. I want to make sure we give full time to our speaker. Welcome to the Robert Allen Memorial Hematology Symposium. I'm John Gutman. I direct the allo transplant program here at the university. And it gives me great pleasure today to be able to introduce Dr. Dan Pollyea, who's going to speak to us about novel therapies in myeloid malignancies. I can't imagine any of you don't already know who Dan is, but Dan has been in our group for over a decade now, directing our leukemia AML program. A renowned, I think, fair to say, internationally renowned figure in the field, been a critical leader in basically every important AML study over the last decade, and has been a real leader in our group at helping to push forward venetoclax and azacitidine, which has led to such a paradigm change in the treatment of AML, and a great clinical partner, a national leader, the chair of the NCCN Guideline Committee on AML. So a good person to hear about myeloid malignancies and therapies. I just will remind everybody that there's information in the chat box on claiming CE credits, and we'll try and I think hopefully have a question and answer session at the end of the talk, but you're invited to raise your hand and we can unmute, or you can enter questions in the Q&A or chat boxes. So take it away, Dan.
Thanks so much, John. I really appreciate that introduction. It has been over a decade, which is amazing. And this is just such an incredible program to spend that amount of time in, and so many fantastic, wonderful people that I've had the privilege to work with here. And I think we've had a lot of success, and that's a testament to the people in this program. And I think, as you'll see, a lot of the things we're going to talk about, some of the major contributions that have been made in the field have had a firm stamp on them from here at the University of Colorado at our program. And I also just, I've had the privilege to give this, to speak during this lecture series once or twice before, and it's just, you know, I think a really important time to acknowledge the contribution that Dr. Allen made to our program with respect to his leadership for decades, his scientific contributions to the field, and his generosity in the form of endowed chairs that he and his family have left our group, one of which I'm a proud holder of. So thanks so much to the Allen family for everything they've done for us. I love this topic. This is just super exciting. Lots of different directions to go. I tried to harness it as best I could, and hopefully do it justice. But like John said, I'm definitely planning to have time at the end for some conversation. So here are my disclosures. And before we get any further, my second disclosure is that I photograph very poorly, and that may be for reasons beyond anything having to do with the photographer, but I do want to bring it up because I feel like I was recently trolled by the Ernst Lab on Twitter, and I need to clap back here. But it is true that this is a absolutely ridiculous picture, and I think the photographer was actually trying to get up inside my nostrils for the picture, and but again, I don't know how much he has to work with, but it did give me an opportunity to go back and look at some of my other headshots that I've had here at the University of Colorado. Thought I would share them with you. So here was actually almost exactly 11 years to the day that that I came here. This is the first picture they took for me, and this was when I only had one kid, and obviously much younger, lots more hair. This was sort of middle of my tenure here, when I looked like a deer in the headlights, because that's kind of how I felt. And then got some other bad advice from a headshot photographer around here to not smile. leading to a picture that looked like this and was has been justifiably mocked by many. But the other thing I thought was funny is in 3 of the 4 pictures here, I'm wearing the same tie. And I think I'm the only person left in our program still wearing a tie. I guess Sherbanow wears a bow tie, but that definitely doesn't count. So so here's my latest picture that I just had taken, and I think I'm gonna try to keep this one for decades, like most professors do, never update it and live forever that way. Okay, so thanks for allowing me this little trip down memory lane. So the topic was novel therapies in AML and MDS. So I want to take a bit of a detour before we get into this topic because I think it's really relevant. So what is the difference between AML and MDS? So I think it starts by thinking about what exactly we're doing when we're naming things. And going back to Confucius, he said the beginning of wisdom is to call things by their proper name. And so it's important to distinguish things by name and identify them that way. But then I have a quote here from this impressionist French painter, Pierre Bonnard, who said that the precision of naming actually takes away from the uniqueness of seeing. So maybe there's a bit of a reason not to try to name things exactly and to identify things perfectly. But regardless, I think the reality here is that when you try to parse out a difference between AML and MDS, you're gonna have the system break down because comes a time when it's a transition between 2 diseases that aren't 2 diseases. So I think it's important to remember that myeloid malignancies are on a continuum, and AML is potentially the final common pathway of all these myeloid malignancies, whether it's P. vera, myelofibrosis, MDS, whatever, CML, they can all end up at AML, but on the continuum, on the spectrum, how do you really tease apart what to call something and how important is that? So I like to use this slide as an example to give you some of the ancient history here of AML and MDS classification. So, you know, the way I like to put it is that in 1982, we received these ancient tablets from the FAB committee telling us that, you know, the difference between AML and MDS was at 30% blasts, and the field agreed, or the field sort of assented to this, and that was how you defined this difference. But then in 2001, it's almost like a scroll was uncovered by the WHO and, you know, written in Aramaic or something, and that, you know, when this was all pieced together and translated, we were all shocked to see that, oh, actually that number was 20%. But of course, we all just adopted this dictate. I mean, this is how silly it is. You know, it's a people in a room deciding when one disease stops and another one starts. And of course, the disease doesn't care. You know, there's no 20% cutoff in the disease's mind. It is the same disease. So, I mean, there's all kinds of flaws here. You know, and let's just go through them. So let's assume that, yes, 20% is the proper way to distinguish 2 different diseases. And spoiler alert, it's not at all. Could we even do it? So Eli Esty had this recent review before he passed away, you know, kind of critiquing some of the data and the statistics behind this. And, you know, he said, even if 500 cells are enumerated perfectly accurately by a pathologist, then, you know, the confidence interval surrounding 19% and 21% overlaps significantly. And we know how silly this is. I mean, that would be the difference between MDS and AML. And furthermore, there's some data from, I think this was MD Anderson, but 4 hematopathologists had not perfect concordance when they all looked at the same specimen, the same patient bone marrow sample. So, you know, 4 different opinions, and you don't get anything approaching, you know, 100% consensus there. So, you know, I think so if we can establish that it's kind of impossible to accurately make a distinction around 20%, then I think we can also go into the argument about why would there be a biological difference between MDS and AML around this? So start with the premise that 19% blasts is the same disease process as 21% blasts, and just work that backward to its logical conclusion. Is 15% any different than 25%? Is 10% any different than 30%? I think you can see where I'm going with that argument. But I think, we do recognize that these are different diseases, or they can be different diseases. So when does MDS sort of become the same as AML? And when is MDS a distinct entity? When does this difference go away? So I turn here to our colleague Brett Stevens in the Jordan lab, who showed on a biological basis that this probably happens as soon as there are increased blasts. What the pathologists very smartly call high-grade MDS. That's not a clinical MDS term that clinicians use, but the pathologists use it all the time. And I think it's a very important one. So, Brett showed in the lab that when MDS starts to have increased blasts, then biologically it's very much indistinguishable from AML. And what is increased? Is that over 5%? Is that over 10%? I think that's a legitimate debate, but I think MDS without increased blasts is a distinct entity from AML, or AML from MDS. So that's at least how I've been thinking about it ever since seeing Brett's work. So just more data that this distinction we try to make between MDS and AML is very flawed. This is a paper just from this past year from our colleagues down in Texas, in Dallas, showing that if you look at survival curves for patients with MDS and AML who both have a complex karyotype, there's no difference. Now, there are differences in how these patients were treated, of course, and there are differences in ages and things like that. But the outcome that patients care about, survival, is not any different. Same thing, also just a publication from this past year in Blood. If you look at p53 mutated MDS with excess blasts and p53 mutated AML, and compare again survival, you see no difference. So it doesn't matter if you have MDS and less than 20% blasts or AML and more than 20%. If you have a p53 mutation, the disease doesn't care. Your outcomes are the same. Again, these patients were treated differently, and there are some differences there, but the disease behaves the same. This is again from Eli Estes' recent review of this topic, but looking at their data in Seattle for overall survival and event-free survival for our patients with high-grade MDS, which is MDS with increased blasts, just like Brett showed us, that should be indistinguishable biologically from AML. No difference in outcomes there, clinical outcomes there. And then we look at the MD Anderson experience. They kind of usually have the most patients and get the last word on these types of analyses. And with a lot of patients, they showed no survival differences in all patients and younger patients treated with intensive chemotherapy when you stratified them by percentage blasts. So less than 20%, the blue line would be MDS, and then sort of what they sometimes call oligoblastic AML, AML with 20 to 29% blasts versus 30% plus blasts. So this is, a distinction without a difference is, I think, how we could think about this. Unfortunately, this way of thinking about MDS and AML, it's not just sort of a benign, whoops, we kind of, missed the boat on how to think about this disease. It's had real consequences. So, AML studies only allow AML patients. They don't allow MDS patients. And you look at the numbers since 2017, 9 therapies have been approved for AML, 1 for high-grade MDS, and that really is just an oral formulation of a drug that's been around. So, all of these treatments theoretically would have been effective in what we were calling MDS, high-grade MDS, biologically the same disease as AML, but these patients were prevented from receiving these treatments and were now prevented from prescribing them. So, the way things work is that high-grade MDS patients, typically they first get a hypomethylating agent. And, realistically, most of them don't respond to this. When they progress to AML or, just fail to respond, they have worse outcomes when you apply any treatment to them. And so this has been shown with the CPX-351 therapy, and Amanda Winters here and others have shown the same when you give these patients venetoclax-based regimens. The pre-treatment for MDS with an HMA that you're required to do sets these patients up to not respond to the next therapy that would otherwise potentially be active. The other thing is just it's difficult to enroll these patients on studies because, once they have MDS and are treated with a hypomethylating agent and then progress to AML, then you have a newly diagnosed AML patient that is excluded from most clinical trials because they have had prior therapy for MDS. So it's this loophole that has really prevented progress. I think Eli also showed that an MDS patient who has less than 20% blast is less likely to receive intensive induction chemotherapy, which in some cases was associated with better outcomes because it's MDS, it's not AML. And then another consequence of this, I think it's interesting, is the venetoclax clinical trial for MDS, which is actually ongoing. They dose reduced the venetoclax to 14 days versus 28 days because of a perception that the MDS patients are somehow less resilient compared to AML patients that evolved from MDS, which I don't think is an accurate way to think about this, but there's all kinds of biases that come in when you start talking about MDS versus AML. And I think those have been limiting. And then finally, this is a horrible thing that's been with our history that people like John got fixed, but for many years, allo transplant was not covered for MDS patients. So same disease as AML biologically, but we had all these limitations in treating it. So the field is listening, and this past year in Vienna at EHA, and then just a couple of weeks ago in Blood, there was this publication from a group calling themselves the International Consortium, I forget, ICC. It's basically the ELN that's including some US-based people and other people around the world. And they're trying to fix this. So this is how classification, according to them, should be going forward. So if you have any of these different subtypes of AML with particular gene mutations or chromosomal abnormalities, you can be labeled as an entity now called MDS/AML as long as you have 10% blasts. So if you have 20%, then we'll just call you AML, but 10 to 19% blasts we'll just say is MDS/AML. And I think the implication is that we'll be able to treat these patients on AML protocols, or I should say, we'll rewrite the protocols to allow MDS/AML to participate, which makes a lot of sense. So, a problem that's been in the field that I think is being fixed. Okay, so that was a major caveat, but I think a necessary one. So let's get to sort of the topic at hand. What are some novel therapies in AML and MDS? And again, no way I can summarize everything in this hour, but I've chosen some things that I would like to cover. And again, lots of other directions that this talk could go in, but let's see how we do with this. So, we have to start with venetoclax, but, it's a fair point that venetoclax is really no longer novel. It's been approved since 2018. Those of you who've been around in our program know we treated one of the first patients with AML ever with venetoclax right here back in 2015. So it's very much old hat for us here. Some places in the country and around the world are just getting experience with it, but we've certainly moved on. So how have we moved on, or how has the field moved on? I think there's a lot of interest going forward in thinking about venetoclax combinations. So I'm going to cover a few of those here. So I want to first start with venetoclax in combination with genomically targeted therapy. So AML, kind of unlike almost any other field, maybe lung cancer is the exception, is one where we really have been able to home in on and exploit single gene mutations in our malignancy in AML and create targeted therapies for those gene mutations. And so one of those is IDH. So the IDH2 inhibitor, enasidenib, was combined with venetoclax in relapse refractory AML. This was last year's ASH presented by Steve Chan. This was work he did in combination with MD Anderson. And, you know, all of these studies are going to be very small numbers. So we're just sort of getting at the very beginning stages of this field. But, you know, basically showed that there was there were some responders and some durable responses with this doublet combination in relapse refractory patients. Now, personally, I'm not so sure that this is going to be a super effective strategy. I think a lot of times when we look at these patients in these studies, I mean, a venetoclax naive population that gets venetoclax based regimen for relapse refractory disease, you know, has a response rate already of around 50%. So we're going to have to see a lot of data, a lot of patients, you know, and that's hard with IDH mutant and some of these other subsets because the numbers are small, but we're going to have to do this in a lot of patients to make sure that the effect we're seeing isn't just the venetoclax effect. The only way around this is to take venetoclax exposed patients and then treat them with venetoclax plus enasidenib, I suppose, and somehow show that you can restore sensitivity to venetoclax. But there, I think maybe the only signal we're going to be seeing is sensitivity to enasidenib. And I think a person could reasonably question why you would continue the venetoclax in that situation. So, you know, we've kind of taken a mixed approach to this. This is, of course, all off-label outside of clinical trials, but you know, there are times when we have done this kind of off-label with commercial supply. But I think the jury is very much out on whether a doublet like this is really going to be the way to go in the field. So what about a triplet? So, you know, most of us in the relapse setting, when we use venetoclax, which has become extremely common, I would say the standard of care in most relapsed AML situations, even though this is, of course, an off-label indication of venetoclax. Again, extremely small numbers. This actually was published, but you know, with this triple combination, they had you know, a very small number of patients that in the newly diagnosed and or relapse refractory setting that they showed. I think it just kind of suggests that this is feasible, but not too much we can take out of the actual data here, other than this is happening in controlled clinical trial settings, and I think should be done with a lot of caution outside of a clinical trial. So enasidenib we talked about. What about ivosidenib? This is the IDH1 inhibitor. So of course in AML, about 20% of patients will have an IDH mutation. You know, maybe 2/3 of those would be IDH2 versus IDH1. So ivosidenib is the IDH1 inhibitor. This was data presented just at this past ASCO by Curtis Lakowitz, who's now at Oregon. And he showed, again, you know, small numbers, but in both de novo and relapse refractory AML, either doublet or triplet combinations. It's a little hard there's a lot going on with in a slide like this with respect to heterogeneity of patient populations and who's getting what. But there, again, may be some enthusiasm for doing this going forward. You know, 9 patients de novo getting the triple combination and showing 100% response rate doesn't you know, doesn't really move the needle in this field. You know, so we need to see a lot more patients, but this is happening, and I think there's a reasonable amount of enthusiasm for it. What about FLT3 inhibitors? So, you know, FLT3, about 1/3 of AML patients will have a FLT3 mutation. We've got midostaurin, which is approved as a FLT3 inhibitor in the upfront setting with chemotherapy. We've got gilteritinib, which is approved in the relapse refractory setting as a FLT3 inhibitor. As a single agent. So what if you take a FLT3 positive relapse patient and combine gilteritinib with venetoclax? And so again, you know, you really have to bin these in a lot of different ways because, you know, venetoclax is quite active in this population. Gilteritinib might be active. So if you take a venetoclax exposed patient and give them venetoclax plus gilteritinib, are you seeing the effects of the venetoclax at all, or is that just being driven by gilteritinib and vice versa? So a little bit bigger numbers here. I think something might have been published just in the last day or so on this, but a pretty respectable response rate. So again, this is FLT3 mutant patients who have not been exposed to gilteritinib or any other FLT3 inhibitor getting the combination. And, I think that this response rate is maybe higher than what we would expect to see with gilteritinib alone. I think reason to maybe be enthusiastic about this strategy as well. In our own analysis, FLT3 in the newly diagnosed setting with venetoclax plus azacitidine has a response rate that is really no different than FLT3 non-mutated patients, but we're consistently seeing that things like event-free survival and overall survival are impaired by FLT3 ITD. So I do think that this is an Achilles heel longer term with venetoclax-based regimens that we need to address, and whether that means that we throw it all in up front and give venetoclax, azacitidine, and a FLT3 inhibitor to every FLT3 positive newly diagnosed patient, or pulse it in later in treatment, when a patient's in a remission perhaps with MRD, and add in a FLT3 inhibitor and alternate with venetoclax-based regimens. I think there's a lot of interesting ways to do this here. So we'll kind of see going forward. So, I think the important questions going forward for these approaches are, what's the tolerability going to be like in the relapse refractory setting? I think, especially with the FLT3 inhibitors, there seems to be, a lot of myelosuppression with the triple combinations. We've seen that in some of our own patients. We wouldn't necessarily expect that because gilteritinib, for instance, alone isn't all that myelosuppressive. So I think that there is something that this is going to be something we really do need to look out for, is the toxicity of these types of approaches for this patient population. And then, kind of like I was saying before, do we go all in with all these treatments up front, or do we save some of them for MRD positivity or even relapse? All right. So moving on beyond genomically targeted therapies, there are other ways to subset AML patients. And, one of those that's really intriguing is to look at retinoic acid receptor alpha, or RARA. So in a normal situation, retinoic acid binds to RARA. The retinoic acid is the ligand, and that impacts myeloid maturation. We know that in APL, there's excessive RARA expression, and when you can't bind up the RARA with the ligands, that leads to uncontrolled proliferation, as well as dysregulated maturation. And so we know that this is a success strategy to use ATRA to bind up all those extra receptors in APL. But what we've learned is that about a third of non-APL AML patients also have increased RARA expression. And tamibarotene is a really good agonist of RARA. And so the thinking is that in these 1/3 of AML patients, if you can bind up their extra retinoic acid receptors, you can restore normal myeloid development. And so that's the idea behind tamibarotene, and a clinical trial that actually we're doing here, that Christine McMahon, my colleague here, is the lead PI for. So it will ultimately be a randomized trial, but all patients have to have RARA overexpression, and patients get randomized to receive venetoclax plus azacitidine plus tamibarotene versus venetoclax plus azacitidine alone. And these are all newly diagnosed AML patients. And so we've started enrolling patients here. Very excited to see if this therapy pans out, and if we might have a better way to treat those patients with the RARA overexpression. So what about treating patients with intensive chemotherapy and adding venetoclax to it? So we've talked up to now just about low intensity strategies. The folks at MD Anderson have done this with FLAG-IDA, their kind of preferred intensive induction chemotherapy regimen, and they've added in venetoclax to that regimen. And they showed pretty compelling data here that they published just within this past year. Very high response rates, a lot of CRs, mostly CRs, very impressive MRD negativity when they give fit, newly diagnosed AML patients an intensive induction chemotherapy regimen plus venetoclax. And so, I think that this is certainly an appealing strategy in the field, and a lot of people, I think, are moving to this. There is, importantly, an ongoing randomized clinical trial right now, newly diagnosed AML patient, fit for intensive induction chemotherapy, getting randomized to standard 7+3, the induction regimen most of us outside of Houston use, versus venetoclax azacitidine, actually. And so there'll be an opportunity to just sort of compare outcomes there. It should be very interesting to see how that study reads out. That might be a while. I think that study's just getting underway. We here have asked for many years, like, well, who needs chemotherapy? Do we need to blast away with regimens like FLAG-IDA or 7+3, or is venetoclax plus azacitidine as good or better? And so we've had an ongoing clinical trial here that we're about halfway through, looking at newly diagnosed younger patients with adverse risk disease biology for whom we would predict intensive induction chemotherapy would have a less than 50% response rate, and we are instead giving them venetoclax plus azacitidine. And so we're very excited about this. Hopefully we'll be expanding it to another center within the year, and we think getting this information out there will be very important to inform future studies, especially for those who think that it's mandatory to give patients who can receive intensive induction chemotherapy and intensive induction chemotherapy, whereas we think that may need to be rethought. And I already told you about the multi-center study happening with the randomized study, but I think in coming out of Vienna just last month, I think we are all feeling the reverberations of this study that has not yet been published, but was presented on behalf of the German group, where they basically looked at patients who got randomized to receive 7+3, standard 7+3, versus just plain old low intensity decitabine. And this was these numbers ultimately were matched for age and de novo versus secondary AML, but no difference in survival. So all of the years of sort of insisting on patients getting intensive induction chemotherapy, it may all be kind of coming to a quicker end than we even anticipated with data like this. So I think a lot needs to be rethought in AML in the setting of data like this. And this is just decitabine. What if we were looking at venetoclax plus an HMA? And we'll have that data soon. All right, so moving on to a completely different target, CD47, and there's an antibody to this in the form of magrolimab. So this is interesting biology, been worked out just the last couple of years over at Stanford by Ravi Majeti and his group. Basically, what they found is that, we know that one of the ways that that normal cells sort of protect themselves from macrophage surveillance is through CD47. And this is kind of the normal way that red blood cells take themselves out of the circulation when they're too old. Around 120 days, we need to get rid of our red blood cells. And this is kind of the way they do it. They have a so-called don't eat me signal that is expressed through CD47 when they do not want to be screened out. But then when that goes away, then they are sort of detected by macrophages and gotten rid of. cancer cells can hijack this system and abuse it basically, and go under the radar and not be detected and surveilled and eliminated by your own immune system. And so the idea is that if you block CD47, you can unmask these rogue tumor cells to be taken out by your own immune system. So it's a really, really intriguing idea. I know it really resonates with patients when we talk to them about it, because it's sort of like using your own immune system to get rid of this. So when we look at sorry, this is oh right. So okay, I didn't show you any data slides there yet, but this is a promising strategy. And here we go. It got a little out of order here. So when we look at magrolimab plus azacitidine, there's been some enthusiasm that this might be an effective strategy for a variety of reasons in a really hard population to treat, the TP53 positive patients. But I think, maybe the shine is coming off a bit. Novel Daver just presented this data. They looked at 72 such patients, P53 positive patients, and the response rates are somewhat lower, particularly the CR rates, than we had seen with smaller numbers, and the median survival seems to be coming back down to earth a bit from what we were hoping to see based on preliminary studies with smaller numbers. Backing up, sorry, to look at, well, what about venetoclax-based regimens in MDS? Yes, this is a very hopeful strategy. We think that this, based on the activity of venetoclax in AML, and going back to the beginning of this talk about the similarity between AML and MDS, it should work. And preliminary findings are really good with respect to response rates. There is a randomized clinical trial looking at venetoclax plus azacitidine versus azacitidine for high-risk newly diagnosed MDS patients, the so-called Verona trial that will be very exciting to see results on. Okay, so just more, I think it's important to let folks know what we're doing here for these patients. We have, again, going back to Brett Stevens' work, Brett has identified protein synthesis as a potential target in MDS stem cells. And there is a very good protein synthesis inhibitor that is actually on the market and approved for CML called omacitaxine. Brett did really nice preclinical work looking at omacitaxine plus azacitidine for newly diagnosed high-risk MDS patients. And we have been doing this clinical trial with the support of Teva for a couple years now, and are getting closer and closer to finishing this. But I can say that as a group here, we're pretty excited about what we're seeing in terms of the ability of this regimen to give us blast reductions and the ability of us to take these patients to transplant with what I would say are really good long-term outcomes so far. So we're really excited about this. This is sort of our main clinical trial that we're running for newly diagnosed high-risk or high-grade MDS patients. So it's really important to discuss this paper that came out in the New England Journal. Those of you who are on Twitter know that this is, for a variety of reasons, been made to be super controversial because of all kinds of provocateurs out there. But, this is, I think, a really important study. They called it the Agile study, mostly done in Europe. They took a newly diagnosed AML population that had IDH1 mutations, and they gave those patients ivosidenib plus azacitidine or azacitidine alone. And the results were very conclusive with respect to event-free survival and overall survival. Ivosidenib plus azacitidine was superior. Now, when you kind of hold this study up against the VLEA study, which looked at venetoclax plus azacitidine in not just IDH1 mutant patients, but all comers, or mostly all comers, you can try to make some conclusions that the survival here was the median survival here was longer than what we saw with venetoclax plus azacitidine. I think those are really misguided, attempts to compare these, but since this study was published, the FDA approved ivosidenib plus azacitidine for first-line therapy in IDH1 positive AML patients. Now, are we doing that here? We're not, because I think there's a couple of reasons. First, IDH positive patients seem to have quite good outcomes with venetoclax-based regimens. We're quite comfortable with venetoclax-based regimens here. We've been doing that for, almost 10 years now, really. And then the other thing is that, if you assume that maybe 10% of all of the patients are going to have an IDH1, and you need to know that information before starting a therapy, unlike venetoclax regimens, which are kind of agnostic to mutational status, you can start them as soon as you can make a diagnosis of AML, then you're talking about waiting to start AML treatment, for days to weeks, when 90% of people will not have that mutation and benefit from that treatment and that wait. So for us here, it hasn't really added up to something that we screen every new AML patient for IDH1 before making a decision. Now, I think there probably are some patients, really elderly or really frail patients that might tolerate Ivo, Ava, Aza better. And I think there might be a time and a place to, specifically look for that. But I think it hasn't become our general practice yet. Another interesting study from EHA, from Harry Urba and one of the cooperative groups. So they looked at newly diagnosed FLT3 positive AML patients who got, I'm sorry, this was not a cooperative group study, this is industry study. They got 7+3 or 7+3 plus quizartinib, and there's a survival benefit. So, we'll look to see how this impacts approvals. At the moment, the standard of care for a FLT3 positive AML patient who can get induction chemotherapy is not just to get 7+3, which was the green line here. It's to get 7+3 plus midostaurin. So, is this better than the current standard of care? It seems like, the midostaurin toxicity profile is not ideal. Quizartinib might be, less toxic. So that might be something to consider. Quizartinib is only effective in the FLT3 ITD setting, not the TKD setting. So there's some differences there between this study and the midostaurin study. So a lot to be worked out here, but it'll be interesting to see, where we end up. And then I think this is what I'm ending with. And it's super exciting to end with something like this. After all the wins we've had in the AML field, it feels like we're on the cusp of another one. So menin inhibitors are coming, and I think we have reason to be super excited about this. So what is a menin inhibitor? So basically the idea is that in a couple of situations in AML that we know of, and probably more than the examples I'm giving, the KMT2A gene rearrangement, which used to be called MLL, and in NPM1 positive gene mutations, there's this situation where menin interacts with KMT2A, and that increases things like HOXA9 and MEIS1 expression, these epigenetic changes, and those lead to leukemogenesis. And so if you can interrupt this interaction between menin and the KMT2A gene product, then the thinking has been that you can restore normal differentiation. And so, how common is this? This is pretty common. This is pretty rare. So KMT2A gene rearrangements only occur in about 5% of AML patients. It's more in the younger patient population. Patients who have topoisomerase inhibitors have greater likelihood of developing these mutations, but they respond poorly to therapy and have worse outcomes. Now, NPM1 mutants, this is much more common, about a third of all AML patients. These are associated with better outcomes, but it remains to be seen how well this strategy is going to work in that population, although we're very hopeful about that. The field has exploded with menin inhibitors. This is Eunice Wang gave me her slide here. At least 5 companies have jumped in with menin inhibitors. I think all of these, most of them at least, are oral therapies and are in different stages of development. So I'll tell you about the 2 furthest along that have been presented at the last 2 ASHs. Cura's drug, which is called ziftomenib, in a presentation of 6 patients. Hopefully we'll get some updates here. You can see, the different profiles and, whether they had KMT2A or NPM1s, but there were some responses here. I think we got really excited when Eitan Stein presented the results from the Syndax study, which is also a menin inhibitor. Again, small numbers, but remember, these are multiply relapsed AML patients. And, to get a response rate over 50%, and I'll also draw your attention, I mean, this is just really incredible. The MRD negativity rate, being what it is at 30% in a relapse refractory population treated with a pill. I think this is just really incredible. And I think we're all excited. We're going to be opening some of these studies here. We're excited that, what we've seen, what the field is seeing. And, I'm hopeful that the next time we give a talk like this, it'll have this type of strategy be included as a FDA approved one. So I'm going to wrap it up there. Definitely wanted to leave time for questions. I see a couple in the Q&A, but thanks so much for your attention. So I see, so feel free, I don't know, Rachel, the best way to do this. I don't think people can unmute themselves in this format, but I see one in the Q&A box. So Annika, thank you. With all these novel agents coming out, are people comparing them to an appropriate standard of care, right? So, this is sort of like what this little Twitter controversy is about, and what is the standard of care. It's always been a challenge in AML because, especially for unfit patients, there really was no standard of care. Azacitidine was chosen, and I think is appropriate, but you could argue that that there were a variety of other options to choose from. Now in the unfit population, I think we have a standard of care. It's venetoclax plus at least HMA, if not azacitidine specifically. So all studies really should be run against that. You can't really fault the investigators, of like the Agile study for running their study against azacitidine alone, because in Europe, venetoclax wasn't approved when it was approved here. Those patients didn't have access to venetoclax. And so I don't know how you can expect them to sort of pivot in the middle of a study and adopt a newer, different standard of care when it's being done in a country that doesn't have access to that therapy. So yeah, I mean, I think, control arms are important. And, this comes up like I kind of referenced in the quizartinib study. I mean, going forward, I would be really most comfortable with a study that showed that their FLT3 inhibitor was better with chemotherapy than chemotherapy plus midostaurin. That's the standard of care. What do you tell a company or a group that, started a study before midostaurin was approved? I mean, I don't know. I think this is something, we kind of have to sort out. I mean, if the FDA approves quizartinib based on a comparison to 7+3 and not 7+3 plus midostaurin, and it's available, I don't think I would say I'm not using it because no one compared it to midostaurin. If I think it's going to be better, safe, or whatever, then so I think it's personally not as controversial as some people out there are making it to be. All right. Well, if there's nothing else, thank you guys so much for your attention, and have a great rest of your day.
Hey, Dan, I think there was just a question that popped up.
Oh, sorry. Okay.
I can just read it a few questions coming in. So
Okay.
In fit younger patients, are you offering Ven/Aza off study?
Yeah, that's a great question. Thank you, Dr. De Silva. I mean, like, this is a tough one because I really think we got to do this study. So, I mean, I'm really, really, we really try to do, if we're going to do this, we do it on the study. Now we have only been doing adverse risk patients who are young and fit, but we think we will soon have FDA approval to do this for intermediate risk patients as well. An adverse risk patient, if I didn't have access to the study, would I give them Ven/Aza instead of 7+3? I think I would do that off label, knowing what I know now. An intermediate risk patient, I don't think I would do that off of a study right now, Dr. De Silva. So hopefully that hurts, but feel free to, it helps. Feel free to email me.
Hey, Dan, can I jump in with a comment
please.
on that
Yeah.
too?
Yeah,
I mean, I think a point that I would make that I think we do feel a little bit more comfortable about is sort of the patients in the 60 to 75 age range who we think, the data around induction and long-term survival is pretty darn poor. In that space, I think we've had a lot more comfort being very quick to say you're not an induction candidate, and have had good success. And I think we've recently published some data, that if you take those patients to transplant, their outcomes can be great, and we can get them to transplant probably healthier and fitter. So, I think in that space, I think we have a little more of a comfort level and feel that it's a little less of a controversial topic.
Yeah, no, thanks for bringing that up, John, because I was making some assumptions with this question. So yeah, let me clarify and reiterate what John just said. When we say younger around here, we're really talking about less than 60. And so that's where I was sort of hemming and hawing. So less than 60, adverse risk disease biology, please send them to me for the study. But if there's if that's not possible, yeah, I probably would just give them Ven/Aza. Adverse or intermediate risk less than 60, please send them to me for the study. If that's not possible, I would probably induce that patient. Over 60, it's a settled kind of thing here. So I would say over 65 around here, no one's getting induction unless they have core binding factor AML, the 821 or the inversion 16 for the most part. 60 to 65 is a bit of a gray area. It's kind of a discussion with the patient, but we lean strongly toward venetoclax for those patients.
I don't know. Can you see the?
Yeah, now I can see. Yeah. So this is Madeline Alexander, does stem cell treatment for MDS affect your eligibility for Ven/Aza if the stem cell treatment didn't work? So maybe the stem cell treatment is being referred to here as a transplant. I'm gonna guess that's what's meant here. So a patient with MDS who gets a transplant and then relapses, sure, we would consider a venetoclax-based regimen for that patient. If the stem cell treatment is intended to mean like a stem cell directed therapy, like our omacitaxine azacitidine clinical trial that Brett Stevens sort of provided all the preclinical data for, yeah, I mean, we have done that in non-responders to that regimen to put them on a venetoclax azacitidine regimen, and I think that's a good strategy there.